All right, well, very happy to join you. I've spoken to this group before and enjoyed it. For those of you who were present at that time, some of what you're going to see is the same, because we were anticipating trying to get to a point where we could start changing how we pay to reinforce providing value in the healthcare system. What's different now is that we're further along. So this is more of a report on where we are and what I think is going to be a very exciting year in Ohio about actually getting traction around transforming how we pay toward value. This activity comes in the context of a lot of work at the state level. I won't go through all of this, but remember 4 years ago, when the governor came in, we were in a pretty difficult spot. The state had an $8 billion hole in its budget, and Medicaid was growing 6% or 9% every year. For 3 years in a row, it had grown 9%. And at the time, we were under a federal mandate to expand the program to more people. So we knew under those circumstances, if we did that, it threatened to swamp the system. So we immediately tried to get a handle on modernizing the program in a way that started to hold down the rate of growth in Medicaid. We didn't want to kick people off the program. We didn't want to take away preventive benefits. Those are the ways states usually save money in their Medicaid program. Instead, we tried to take on this idea that a few people were most expensive, and often they were expensive because something about the system broke down around them. So wherever we could coordinate instead of fragment the system, we had an opportunity to provide a better service and better outcomes for people. The big example for us at the time was we had a lot of people unnecessarily in nursing homes, the very most expensive setting for care, because we didn't have enough access in the community to be able to divert folks into community alternatives to nursing homes. So we moved money out of nursing homes into community-based services, saved a tremendous amount of money. So many of the things in that first column there were things that people wanted, but there were political reasons why it was hard to get to. But we were able to take some of that on and transition money out of parts of the healthcare system and move it into other ones. We moved on then to look at some of our infrastructure. I won't go through all the examples here. We combined departments, we created a new department, things that in other administrations have been just real killers, because when you start moving around your organizational thing, you're challenging turf in a way that can really be difficult to pull off. But when the governor recruited this team of directors, he said to them, you're on a team first and you're a director second, and only if you agree to that are you allowed to be on the team. So everybody came in with this expectation that in some cases they were going to have to give things up. So we combined mental health and addiction services. We created a new Department of Medicaid. But the thing I'm most proud of in this category, we took a really horrible way of determining eligibility, where Ohioans had to go down to the county office and basically sit there and go through a long list of questions to figure out if they're eligible for Medicaid and other programs. We put that online October 1 a year ago, and now there's one question. What is your income? And if your income is below 138% of poverty, you're enrolled in Medicaid online. And that's had a real impact in terms of simplicity for people accessing the system, including in some of your settings where before, if a person was coming in without coverage, they would have to leave you without coverage and go figure that out and then come back, as opposed to now just enrolling. Most often it happens at the point a person enters a hospital, they're able to go online, get coverage, enter the facility with coverage. It's had a real impact. All along, though, the governor really wanted to get here. And, you know, it's this idea that there's so much about what you do that you do despite the financial incentives. You know, in a lot of ways, folks have ended up on this treadmill where because of how we pay, you have to get down to units of service where you can move a lot of people through to keep a practice viable. And that really runs against, in some cases, good medicine. Being able to spend more time with folks for whom a little bit more time really makes a difference. So, you know, we know you do that, even though the financial incentives are not necessarily there to reward that. So how can we start thinking about changing how we pay to support value and actually keeping people well? So this is important for Ohio. Everywhere I go, I use this picture. We're the red bar. The height of that bar is per capita spending on healthcare. So in Ohio, we spend on the high side. Our residents spend more for their health care than residents in all but 17 states. And our position left to right is in terms of health outcomes. 36 states have better health outcomes than Ohio. There are a lot of ways to measure this. This happens to be the Commonwealth Fund scorecard on state health system performance. It's a whole bunch of measures rolled into one where a state gets ranked. But on most measures, Ohio tends to be in that bottom quartile in terms of health outcomes. So depending on what measure you're looking at, that can be different. To the governor, this is the value statement, right? If he's calling CEOs in Texas saying, we want you to relocate to Ohio because we're the 36th healthiest state, it's difficult to pull that off. So from the beginning, he's seen value in healthcare as really a matter of economic development for the state. Can we hold the line on expense, but improve outcomes? And that's the value challenge we want to take on. So a lot of the engine behind that, and I know everybody here understands this, you know, we really do get what we pay for in healthcare. I'm always frustrated with the argument that the competitive market, the free market system doesn't work in healthcare. Well, it works with a vengeance. It's just that it's calibrated to reward volume. When you pay on a fee-for-service basis, the competitive market encourages the creation of a whole bunch of units of service, whether or not they're necessarily adding value. And high-quality units are not necessarily rewarded more than low-quality units. A unit is a unit is a unit. So the system has kind of driven this overconsumption of certain things, but then not provided an adequate supply of other things, like primary care, for example. So how can we reset some of the basic rules of competition to reward keeping people well? What would that look like? This, of course, is, you know, a broad national debate around value and how we might change payment. As a practical matter, that conversation usually occurs in these different levels. We are, if I drew this to scale, we are basically a fee-for-service system today. You know, about 95% of that picture would be fee-for-service, with a little bit of population-based payment around the edges. There are some accountable care organizations. There are some patient-centered medical homes that are responsible for total cost of care, but for the most part, we're a fee-for-service environment. And then in the other extreme, you can imagine something in the future where there is something like an accountable care organization, where an entity is responsible for being accountable for all of the person's needs for some predetermined amount, and then they hold the risk for keeping that person well. So a population-based model. But the reality is that between where we are today and that, there's a lot of distance to cover. And in between, there are about 50 acute episodes that account for 50 to 70% of what we spend. So as a practical matter, there has to be a sense of value for those episodes that end up consuming most of our healthcare dollars. So we in Ohio believe that there is something to this accountable care idea. However, for where we are today, is that health system A or health system B? Is it a health plan or a health system? We didn't want to be in a position of refereeing who gets to be an accountable care organization. Instead, we started one level below that to ask the question, what would it mean to support a better version of primary care? Or when these high-cost episodes occur, how can we reward value in how people provide those? A better version of primary care and value in high-cost episodes where they occur, that starts to address much of the system and then can be the building blocks for others in the future to figure out how to put that together into an accountable care organization. So that was the idea. So we translated that into this goal. What I'm working up to is what we're actually doing right now. What this came from is there was a federal grant, it's called the State Innovation Model Grant, where states were encouraged to essentially function as a catalyst to bring together payers, providers, patients, and have a conversation around how to change how we pay. Ohio won one of those grants. We received $3 million. We put $3 million of our own money in, and then used that over the past 18 months to arrive at this position. So it was a very open process. Many of the folks, many of you in the room participated in one way or another in that. It was some of the most fun professional policy work I've ever done. Just hearing folks basically argue what it might mean to turn payment on its head. Where we landed was in this territory here. We are willing in the state to use everything we've got and point it in this direction. So we are willing to tell all of our Medicaid managed care plans to do this. We're willing to tell our state of Ohio employee health plan to do this. And then we've partnered with other commercial payers to do this. What do we do? In primary care, we are lucky in Ohio to have one of 7 comprehensive primary care initiative sites in the country. This is in Southwest Ohio. What they're doing is building out what an enhanced patient-centered medical home could look like in partnership with payers who are then willing to pay those practices for being an enhanced patient-centered medical home. What they're learning there, things like how to attribute a patient to a practice. Do they count to me or do they count to another practice? What are the things that you really need to have available 24/7 to that patient so at the point they need to see primary care they have access? What are the relationships that need to exist between primary care and the health systems to follow that person as they move through other settings? These are all the sorts of things that the Comprehensive Primary Care Initiative is sorting out. We are learning from that, and in the spring, we want to generalize their model and roll it out statewide, providing some infrastructure support for practices that change, providing an enhanced per member per month payment for practices that coordinate in that primary care setting, and for practices that are able to hold down the total cost of care of their population, having the insurance companies take some of that benefit that's accruing to them and share it back with those primary care sites. Now, what's significant about this is we have each of these organizations agreeing to do that. Part of the challenge of payment innovation activities in the past has been, if Medicaid does it, that's great, but you may only have 10% Medicaid in your practice. Or if Anthem does it, maybe you've got 20%. It's hard to change your entire practice for what little reward might come along with 20% of your patients. But if you make the investment to become a patient-centered medical home, and you've got the EHR, and you've got an ability to coordinate and stay connected with your patients as they move through other settings, if you make that investment, these plans have said they're willing to pay more for that because they know it's going to save them money down the road. The other side of this is episode-based payments, which I'll go into a little more detail here in a second. So I won't spend a lot of time on patient-centered medical home. I know many of you already are kind of the state's experts in this area. I do try to, though, always share a slide that talks about how comprehensive it is, how challenging it is, how intensive it is to actually become this. We're lucky in Ohio to have some tremendous resources. In addition to the association, your association, we have these regional health improvement collaboratives that are really taking leadership and trying to organize communities around what would it mean here to transform a number of practices to becoming patient-centered medical. That work is underway anyway. What we're trying to connect to is if you go to the trouble, we should reward you financially for having done that. So on the episode side, this is a little different. For patient-centered medical homes, it's really grassroots and labor intensive. A community has to make a decision that they're going to really support a better version of primary care and really work toward that, try to bring practices along, make sure the technology infrastructure supports a flow of information across settings. It's a very intensive process. On the episode side, it's a little different. We're here, the insurance plans have a tremendous amount of information about the claims they pay for these highest cost episodes. They can see it, but you can't. Why not take all of those costs, all of those claims related to an episode, and just give it to the person in the best position to make decisions about care so they can see all aspects of that cost? Think of a joint surgeon, for example. The surgeon knows what they're getting paid. They don't necessarily know the hospital DRG. They don't necessarily know the rehab cost that goes in after the surgery. But we can collect all of that information and show them, and then compare them to other surgeons around the state. And if they are bringing in a low cost of care at high quality, there are physicians doing this today, and all of the benefit is simply accruing to the insurance company. They know you're low cost. You don't know you're outperforming your peers. Why not show you that, so then if you are low cost, high quality, you share in those savings with the insurance company. So that's the idea on the episode side. The model works like this, and I'll run through this quickly, and then if you want to get into more detail, I'm happy to. Part of the problem with episode activities is they become so complex nobody can figure it out. You try to do something prospectively, give you money prospectively for an outcome, but how do you measure the outcome? Who do you give the money to? How does that money get distributed? This is different. Here, step one, patients seek care, providers submit claims, and claims get paid, just the way it is today. But then on the back end, the plan collects all the claims related to a particular bundle, assembles it, risk adjusts it, and then shares back that information with the principal accountable provider, so then they can see their performance relative to others and make changes going forward. You very quickly end up with a picture that looks like this. Now, there are a lot of questions that immediately come up. So let's pick something. Let's say this is I used the joint example. Let's say these are total joint replacement episodes. There are some cases that are so complicated, we don't want you to put that surgeon in competition with others. We just exclude the complicated cases. What we're looking for are fairly routine cases. And then even within those, there are factors that make one case more risky than another. So we brought joint surgeons into a room and spent several weeks identifying the factors they saw as most legitimate to risk adjust on, and used their advice to create a risk adjustment model that then we gave to the insurance companies and said, we want you to adjust your risk based on what they say is relevant. So after you go through that process, you then end up with a risk-adjusted result where this is now price compared against principal accountable providers. So think of each one of these as a joint surgeon, who then, some of them may have 20 cases, some of them may have 100 cases, but this is the average for that principal accountable provider. This is actual fee-for-service data. So these folks in green, they are a great deal for insurance companies already today, because the insurance companies are basically putting the money they're saving from that good work in their pocket. So why not, if you're here, negotiate that you get half of these savings back to you? And if you're here and you know that you can get here and share in the savings, it creates incentive to be sensitive to what your price is. Now it works in the other direction on the left. We have a few very high-cost providers. The next time their contracts are up, are you in network, not in network, what is your price? That starts to be a more interesting conversation. And again, this is actual data. So this is what actually happened over this past year. This is actual Medicaid results for our perinatal episode. This is for just this past 6-month period. Remember, we've thrown out, excluded, really complicated cases. We've risk adjusted everything else. And look at the results you get. Our Medicaid director, the next day after he saw this picture, drove to the hospital on the left over there. Because now for the perinatal episode, oh no, I'm sorry, this is perinatal. He did this for asthma. Here's asthma. So look on the left over there. John McCarthy, our Medicaid director, drove to the hospital furthest on the left and showed them this picture and said, how do you account for this? And this is not treating routine asthma. This is asthma acute exacerbation. So here a person is presented either to the emergency department, there's that decision point. The hospital furthest on the left, in every single case, admitted the individual. It was their policy to admit. None of the other hospitals had that policy. They changed their policy, and overnight, they're now down here in this middle range. So that's an example of how just looking at the information can give you insight where maybe you didn't even know you were performing well, or maybe you didn't know you were an outlier. So we're at a point now where the insurance companies I mentioned earlier that are listed there have collected all this information for perinatal episodes, asthma acute exacerbation, COPD, total joint replacement, and PCI. We have that data, and we're looking at it in charts just like the one I just showed you. Probably in the first quarter of 2015, we are going to send those to all of the principal accountable providers, who will then have access to information that looks like this, where you can see how risky your population is compared to others, where you rank compared to peers. This quality metrics piece is important. I kind of skipped over it in the first version of this. It's critically important. We don't want to create an incentive where to share gain here, you simply don't do stuff you should. So there are a set of quality metrics that, again, the clinicians themselves identified the minimum set of quality metrics they would be comfortable with measuring to know if there had been a good outcome for the episode, you have to meet every one of them. If you don't, you are not eligible for gain share. So the providers in the red here were low cost, but they missed one of the quality metrics, so they're automatically excluded from gain share. If they meet the quality metrics, then they become eligible for gain share. So what are the quality metrics and how did you do is a part of this. This report then goes into a level of detail that by patient, you see all of the claims and you see all of the quality metrics. So there's essentially a page per patient of detailed information. So then as a provider, you can drill down into that as much as you choose. We wanted to err on the side. We've heard this over and over. The insurance companies are holding all this information. If I could just get access to that, I know there would be information there that would help me improve. This is now access to everything they have, not only on your claims or specialists, but on other related claims too. So it's potentially pretty powerful. So along the way, as we were working on this, just 3 weeks ago, the federal government announced that they're going to have grants for what are called practice transformation networks. We had planned in our work to provide support for practices that want to improve. That's critically important to provide technical assistance to transition to patient-centered medical homes. But then also, if you're a specialist and you're one of these principal accountable providers and you get this report and you want to do better, what access do you have to resources? At that moment, we wanted to make sure folks had very good access to resources so then they could take it to the next step, however they choose. This is perfect for that. So we're working with the regional health improvement collaboratives, we're working with various associations to basically not one by one apply for these funds, but we're going to propose an Ohio practice transformation network where we assemble all of our resources and make them available for PCMH transformation and for the specialty practices that are eligible for episode payments. I think this week we send a letter of intent in. By January we'll apply for this, and I think Ohio would be very competitive for that. But that's something that I think many of us in the room will be, it'll give us an opportunity to work together to think about how to pull that together. So I've covered most of this already. I mentioned we received a little grant to do this design work. We have now applied for a federal grant to actually test and roll this out. We were ready to roll out these performance reports this month. However, we have heard that the federal government is going to announce the next round of test grants within weeks, and I think Ohio is going to get that, and it's going to be in the range of $75 million. So those are resources on a scale that will really help us support things like practice transformation and take all of this to the next level. So instead of putting the performance reports out ahead of that, we've held them, and then when we get that award, we will announce when we're going to release those reports, and that'll be our first step of the testing process. That is timed to occur early in the new year. So like I say, I think next year is going to kick off a new round of attention on Ohio in terms of what we're doing. What's unique is how we've been able to hold together a multi-payer coalition. Other states that have done this tend to have one dominant insurer. If Anthem, Blue Cross, Blue Shield says they're doing something, then the state just goes that way. Ohio is unique because nobody has more than 20% market share. So it's very hard from a practice side to adapt to individual insurers. And the reason I think we've captured attention on this is that we've been able to assemble this group of multi-payer. Okay. Tremendous amount of information on this website, including things like all of our definitions around what an enhanced patient-centered medical home would look like. And by the way, the elements that the payers have agreed to reward financially. Definitions on the episodes, detailed episode definitions. This grant we have in that is actually a pretty good indication of where we're wanting to take the state over the next 4 years, not only in terms of the payment model, but the role of population health, quality measurement, HIT strategy, workforce strategy. All of these things have to be brought together and they come together in that plan. So if you're interested in more information, there it is. Okay, I'm going to stop there. I think the idea is we will have a panel react, and then what I'm most interested in is getting to some of the questions.
Good evening, my name is Phil Cass, I'm with the Columbus Medical Association, and we asked that we have a panel to start out our questions. And I wanted to introduce the panel, you probably know most people. Dr. Mark Alfonso, radiologist, Riverside Radiology and Interventional Associates. He's the immediate past president of Riverside Radiology and the current chair of Premier Imaging Board of Management. Dr. Bill Wolf is the CEO of Central Ohio Primary Care, a collaborative of 250 physicians, and he is an internist. And Dr. David Applegate, family medicine physician in Marysville for over 26 years, recently took a position as Ohio Health Physician Group of Practice Transformation. I'm going to ask each of you if you would be willing to pose a question to Greg and get a response, and then we'll open it up. We're having trouble with the microphone, so we're going to have to, from this side, speak up.
Greg, obviously the expansion of Medicaid is very important in all of this. What is the possibility or the likelihood of reversal of the expansion of Medicaid by the legislature?
The potential of the reversal of the Medicaid expansion, it's a real threat. It's a real threat. I think it was misunderstood the first time through. We had a clear majority of support to expand Medicaid in both the House and Senate. And had we not, we would have not pursued what is called the controlling board option, which was a subset of the legislature that ultimately approved expanding Medicaid. The problem was there were a number of legislators who knew if they cast that vote, they would draw a primary and probably lose their election, so they didn't want to take that vote. So the leadership agreed that a preferable alternative would be for the controlling board to take that vote, not the whole legislature. It was not necessarily a great moment for democracy, but like I say, if we had seen a clear lack of support, we would never have taken it through control. So it became what we viewed as a correction to what had broken down in the House. That dynamic is still there. So the way the budget works is every 2 years, basically everything we do shuts down. Because without an appropriation, you can't run government. So technically, the Medicaid program every 2 years goes to zero, and then the legislature has to reappropriate the program. So there's some conversation around, do we have to get approval again? Well, the answer is we get approval every 2 years. The question is, at what level? So we're going to introduce the budget with the current eligibility levels intact and see if anybody else would presume to try to reduce them. And then at that point, there's a pretty active coalition on standby to oppose a reduction of those eligibility levels.
I'm assuming it's pretty hard to take away coverage once that's not right.
That is what's really different this time. Before, it was a matter of adding something, and now it's a matter of taking away, and I think that point will make the difference.
There was a fee increase for physicians last year. Do you think that'll be maintained in the coming year?
You should lobby Congress to get the federal government to extend it. It's not going to be extended there. However, the primary care fee, the rate increase that essentially took Medicaid up to Medicare levels for a temporary period of time, we agree that the investment needs to be in primary care. So we are looking for ways in our next budget. I don't think we'll be able to get those rates all the way up to the Medicare level because that was fully federally funded. But we're looking for other places to get access to resources to keep those primary care rates up at least some. But the final level of that has not been determined.
Question pertaining to imaging. As you know, a lot of Medicaid patients go to disparate healthcare systems. We don't have access to any of those prior images. That was very important at the time the patient presents about a definitive diagnosis. It's also important for physicians and nursing physicians to know whether somebody had contamination in order to prevent unnecessary complications first. What plans, if any, are in place to address image sharing or access to Medicaid imaging stuff?
Yeah, so access to imaging and doing it not necessarily multiple times, but having access to what's been done. Several things here tie directly to it. So for example, if there's a patient-centered medical home that is in a point of coordination with a person across settings of care, it creates an opportunity to have knowledge of what's occurred and already exists, and already exists in the electronic health record. Another avenue is everybody through the Medicaid program is in managed care. So those health plans are in a position of coordination to know what a person has or hasn't had. So we have several points of possible coordination. But then, as a practical matter, it's how you get that together. I think there's an interesting, well, I'll just stop.
Greg, is it not true that OHIP is going to have imaging available for all of those systems in the state that feed into OHIP, that they'll actually have images available online in 2015? Wouldn't that also address this?
It would. Is that where they are?
They are.
Can you explain to this right here, is this just the cost of an episode, or is this what the physician costs or creates the cost of?
Yeah, so this is the total cost of all of the elements that went into the episode. So for example, and I have a picture of this that's actually very helpful because it breaks it out by hospital, pharmacy, rehab. So any one of these bars is capturing an average cost. If this was joint replacement, there would be a hospital component, there'd be the surgeon component, there'd be anesthesiology, there'd be rehab after, which ends up being very, very important to the value proposition. Pharmacy. And what's really interesting is the incredible variability on a couple of those. For example, pharmacy. A 3 times difference in average cost from one surgeon to another. We tried not to judge good and bad because, for example, I can imagine in joint replacement having more rehab costs could be a very good thing because that additional rehab may be holding down your total cost of care. So we didn't try to apply any type of judgment. We just are sharing the information so then folks can make a determination about whether they think there's an element of their cost that they can go after. Now, one really complicated one is if you're a surgeon attached to a particular hospital, and that's a very high-cost hospital, you can't immediately bring down your hospital's DRG. But it creates a sensitivity to the fact that the reason you're not getting a bonus is because your hospital has an expensive DRG. So it's creating a sensitivity to the different input prices. Now, if you're a surgeon who has privileges at a couple institutions, well, then that might influence where you're doing most of your surgeries if one has a lower DRG than the other.
Is the gain sharing just for the provider, or does it also involve the healthcare system?
Yeah, so this is where you get into the idea that Today, you get none of this, so you have to start somewhere. And where we chose to start was the idea that the principal accountable provider would receive the gain-sharing payment. So in this case, the joint surgeon, if they're here, would receive half of that. It would kind of seem like a bonus because it would be a point in time after the fact. What they do with that, we're silent. So if, for example, in the team, that low total cost of care is a combination of the anesthesiologist in the hospital. So we're hoping it creates a conversation around what is the responsibility of the financial relationship among the members of that team. Who is the principal accountable provider is very important. In the case of total joint replacement, it's the surgeon, it is not the hospital. In the case of asthma acute exacerbation, it's the hospital. So in each one of these, those principal accountable provider definitions are spelled out in front of them.
I think it's a very strange dynamic for a surgeon to be in the position of being rewarded if his costs, the total episode costs are low, talking to an anesthesiologist who gets absolutely no benefit out of any effort to reduce costs, and he's sitting the anesthesiologist and saying, hey, I'm doing great quality care, and the surgeon's saying it costs me money. That's a tough conversation.
Does that conversation occur at all today?
Nothing that friendly.
I mean, it goes both directions because as the surgeon, who are you working with and to what extent do you have some measure of control over that? If there's a very expensive anesthesiologist who's constantly getting assigned to you, it starts to change the dynamic of how much control you exert beyond what is the normal standard. Usually it would not include that. An easier one is the device. You know, a lot of folks, I think, use devices that they really don't think about cost that much because it really doesn't, it doesn't directly affect us. But now that device cost is going to be factored into the total cost of care. So do you take that into account in the decisions you're making? That's, in that episode, kind of the most direct, least conflict-oriented decision that potentially is being made.
It is very difficult to find out from the hospital what a mathematical statement actually costs. What's insurance? Who's insurance? How do you get insurance?
And in this case, what the insurance company paid for it is now what you see. So those claims are now turned over to that principal accountable provider to see how they add up to. Now, in that case, I mean, a lot of the hospital costs ends up just being whatever their DRG is. So you don't necessarily see.
If people would just kind of give me a sign, I'll try to get people to ask questions. Yes, John.
I'm fascinated by this graph. I understand the 95% risk ratio. How do you define acceptable? You know, shouldn't there be an average risk patient who you're paying an unacceptable amount for? You see what I'm saying? The commendable and the acceptable, I'm having a hard time. How do you define those?
Yeah. That's, excuse me, that's really important, and we're leaving that to the plans to set those levels. But what we've asked them to do is set them and keep them for a period of time. So there are a couple really important points. This information will be shared without these lines at first. It'll just be reported kind of where you are as a matter of performance. And then the plans will determine kind of reasonable levels. For us, we think in terms of budget neutrality. So if we're able to cut on the left an amount that covers the right, for us that's budget neutral. So there's kind of an arbitrary financial calculation there that Medicaid will likely make. But we will leave it to each plan how they choose to set those levels. And then they're locked in for a period of time so folks have an opportunity to change and move their position on the chart. So we will say, for a full year, here's the commendable level. And particularly what I'm most interested in is if there are folks in this range who otherwise would get no game sharing opportunity, they would just get their normal fee-for-service rate. They're getting paid the normal fee-for-service rate. But if they're able to pull some cost out of their bundle, they'll become eligible for game sharing. We did not want to do a gotcha. You know, here are your numbers and we're going to pay you accordingly. We wanted to say, look, here's where the model positions you. Does the model work? That's our first question, because we want to make sure it does before we attach payment to it. And if it seems like it's holding up, then here's a date in the future where if you're able to change your performance, then the payers will reward you accordingly.
Yeah, just real quick, I think one of the concerns that I'm hearing a lot from docs, especially, I'm going to review by regards to the perinatal one, and close to what that brought up. I think it's very frustrating at times. I think it's a lot easier for a hospital to get to doctors to be able to meet the control costs than it is for doctors to get the hospital to be able to, like for example, in OB, you know, anesthesia is a cost that gets attributed to us, but we have no control because it's a separate group, a separate contract. Conversations are good, but I think there hopefully will be some sort of way to address that in the future other than conflict or threatening with another hospital. So the frustrating thing about it, I don't think there's anybody here who's like, oh boy, I hope I'm really costing the system a lot of money. I think everybody wants to do what they can to bring value. The frustrating thing would be when the thing that you're doing is really out of control and there's no way to get it done. Does that make sense?
Totally agree. Totally agree. And somehow we've gotten into a situation where much of the system works that way right now. You know, I mean, how bizarre is it that we created a payment system that actually has set it up so you have very little control over many aspects of care directly related to your patient. You know, and I think you wouldn't necessarily choose to do that as a physician, but you've got kind of this administrative system that's built up around you in a way that says this is your part and this is somebody else's part. And what we're trying to do is start to break that down a little and say, well, really, this is your patient, and you should be in a position to make decisions that if it's adding value and are high quality, why wouldn't you be the one to then derive some financial reward? So it is hard because you always have to remember that we're starting from the point that I could come up with a dozen things about this model that are imperfect, and I wish we could have gotten a better version of this. But it's that the starting point is so bizarre and bad that even just sharing this information is revolutionary. The idea that you could look at other claims related to an episode that you're primarily responsible for. I mean, what's shocking is that you can't do that now. So some of the difficulty in this has always been kind of coming back to this idea that it's so difficult now the way we pay that any step is hopefully a better step, even if it still has these imperfect results like, for a while, you're probably not going to control the anesthesia. That's right.
Has this been done for all the specialties?
So we started with 6, and we went through a process where we were very careful on how we picked the 6. One of the most important things were areas where pretty clear definitions existed already, and some folks had experience with the episode, and that it was fairly discrete. For example, I wanted a behavioral health care episode. I wanted something to kind of try to get at mental health services. But it is so variable and so unique and so complex, it does not lend itself to simple definitions. So we focused first on a few things that were very expensive that also had elements to them where we saw huge variation. So for example, this notion of frequency and type of imaging is highly variable and contributes significantly to the variation in cost. So there are elements within the episode that folks can actually make decisions around what's contributed to the cost of the episode. So in combination of kind of all those factors, we then with the plans picked the 6 that seemed like they could have the most early impact. Like asthma acute exacerbation in the scheme of things isn't a lot of money, but it is so specific, and when it's done badly, it's very expensive. Everybody agreed it was kind of low-hanging fruit. Total joint replacement, different. A whole lot of money in those, and individual episodes are extremely important just because they're so expensive. So we tried to pick something where the hospital was the principal accountable provider. We tried to pick one where individual physicians were. So we were trying to get a mix of experimentation on things we could define where people had some experience. And these 6 happened to pop out. Now the idea is, if we get some traction and they seem to work, we'll just keep going. I mean, clearly, if these fail, if the model just kicks out really bizarre results and you all say this thing's not working, we'll just pull the plug. But if it seems to be generating valuable information, then we're ready to go on to the next 6, and then the next 6, and the next 6. All right.
The data that you're showing seems very promising, and we're looking specifically at the physician. The concern that I'm starting to see over the last 2 years is that we're having less control, and I don't see anything being evaluated specifically on the hospital or the patient. And we all feel that the patient needs to have a certain amount of accountability. For example, on your line there, if you have $5,000 that it's costing, and you have a patient that's non-compliant with treatment, and it's going to affect the physician, but yet the patient has no impact to them. And I don't see any reward for the patient for being compliant for their treatment as well. The hospital being rewarded for their staffing and not cutting resources. So lumping things together, I think we're heading down a dangerous path that way. And we're talking about expanding this to other diagnoses. We've got to look at everybody, reward the insurance company for working well with the physicians and reimbursing them in a timely fashion so that everybody is getting evaluated who has a stake in this.
I agree completely. And for example, in this picture, what you just said is true today. Patient compliance is a factor in what is contributing to whether a person is expensive or not, and what the total cost of care is. It's already all in here. Some folks, despite that, are being able to come in lower on total cost of care. Is that because they're able to get cost out of their practice somehow? Maybe it's because they've somehow figured out a way to achieve better compliance or lower no-show rates, so they're simply more efficient. If they're able to do that, today there's no reward for that. If you as a practice are able to decrease your no-shows, there's no real additional value. If you're able to do that, you should get some value. The other thing is, on the principal accountable provider, there are only, the joint surgeon is the principal accountable provider, the OBGYN and the perinatal, but otherwise it is the institution. For PCI, for COPD, for asthma acute exacerbation, it is the hospital that's on the hook as the principal accountable provider. So we intentionally tried to pick a mix that would, and we don't see it as putting that entity on the spot. We see it as giving them an opportunity to share in the financial reward of doing a good job. So again, it's all where you see your starting point. Because today, everybody's on this chart somewhere already. And if you're here, you get nothing for it.
Are there states ahead of us with initiatives like this, and have they shown success? And in what areas have they failed?
Yeah, that's a great question. Some of what we started with initially on the episodes were related to Arkansas. Arkansas had a very aggressive initial push on this. They have since had a leadership changeover and have had difficulty following through on some of what they had set up. So the early signs were very promising around stabilizing, holding down price increases on the bundles they picked to monitor. So we do have that experience. There are a number of states that have done things like episodes, but they tend to bring them online through one major insurance plan. So what is a little more untested is anybody's ability to keep folks voluntarily at the table to actually do this without flipping over into some sort of regulatory environment where we basically mandate that they do it. So for our Medicaid plans, we're mandating that they adopt these models. In a couple cases, that crosses over to commercial plans, because United has Medicaid, and they also have commercial in Ohio. Some of our strongest support, though, has come from the non-Medicaid plans. Anthem, for example, has been very open to this approach. The one thing I learned, everybody has been talking about how they're converting to value-based payments. And then when you actually get in there and look at it, what they're really doing are things like preferred networks, where through their contracting, we'll go with this practice, not that practice. Well, that's not value-based because that practice then doesn't really share in the reward. They're lucky they're in the network, but it's not an explicit tie in payment to value. So these plans essentially are being kind of, we're calling their bluff because they're not really sharing money back to providers. So when you do that, they're saying, well, if we have to do it, we might as well do it in a similar way because then we share the risk of this equally. That is then what has brought people to the table in a way where on the same day they're willing to kind of jump over that cliff together. So it's been a fascinating process. And we had a great meeting where the governor sat in the room with the CEOs and he went one by one and he said, I want your personal commitment that you'll stick with us through the process. And CEO by CEO, they went around and gave their commitment. So there is still something to that. Things have gotten pretty difficult a couple of times, and just kind of recalling that commitment has been helpful to keep it going. Because we're talking about moving a lot of money out of the insurance space into the provider space.
Two more questions. Congratulations on getting the payers to cooperate together. My question regards this slide. You said the payers will decide what level is commendable, what level is acceptable. Is that per payer? So we have different graphs for each payer, or are we going to aggregate data and decide on mass what commendable and acceptable is?
So this is one of the imperfect results. And unfortunately for where we are, the principal accountable provider will get this from Anthem, they'll get it from Aetna, and they'll get it from, now we at least have it in a standard format. So hopefully it comes in a easily compared version. The only way to get this into one report is through something like an all-payer database. And there are regional efforts looking at the notion of what would it take to bring online an all-payer database. So for example, HealthBridge in Southwest Ohio, OHIP, are looking ahead to options like that. There's one somewhat obvious detail, but if you don't think of it, you wouldn't necessarily catch it. It is this. We have Medicaid data. If you ask for it, I have to give it to you because it's public information. So as soon as Medicaid generates this report and somebody asks a public information request, clearly we can't share PHI, but we can share the aggregate data, and we have an obligation to do that. If we took all of these reports and aggregated them into one, the whole thing would become a public document, and we'd have to share this detail on every provider with everybody, including the press. So we made the decision that we were not ready for that kind of transparency. So eventually, I think all of this online would be great. If it's tested so much that everybody absolutely believes in it, eventually all this will be totally transparent. But for now, it's experimental. So we wanted to isolate what is public information to only the Medicaid piece, which then the consequence of that is everybody has to similar. So that's the honest answer for that.
Are the payers concerned that physicians will now know from each report what they're paying each hospital system for each service? And do you think that would tend to equalize the prices that payers pay systems? Or physicians are now going to know that, you know, you exceed, you're paying too much for this compared to Anthem. Is that a concern?
It is an observation that that will somehow affect the market. It will be interesting to see how.
Each one of your businesses has the access to the dollars. If you took that graph where she showed the acceptable and recommended levels and just lowered that level, which you said was the insurance companies took that acceptable and recommended level. What if I said that access should not have a dollar value of physician satisfaction, but what would be more patient satisfaction? Because you drop that level down, you're not going to have very many happy physicians taking care of patients that have to be driven out to whatever your acceptable level is. For whatever reason, maybe it's we're not just getting paid for what we're doing, but we're getting paid for our staff and our office. But I'm really also wanting to know, for the same reason, patient satisfaction, because Medicare and Medicaid patients are often felt to feel that they're second-class citizens. That shouldn't be. They should be treated the same way as everybody else. But they're not treated that way because they don't get the same level of care.
Totally agree. Elements of these quality measures can include the types of measures you're talking about. So that's one way to get at it. And remember, it's back to this kind of point that this is reality as it is today already. So this is just a fact of how it is. And then over here, folks are providing this service at this level with no financial gain for being high value. So you always have to go back to this idea that this is kind of where things are written. Now, the one thing that's most interesting to me, and this is counterintuitive because, you know, I was an economics guy, and there was that triangle where you have access, quality, and cost. And if you want more one, it's going to cost you in the others. So to get more quality, you have to pay more for it. That is not true. That is not true. What we're seeing is a correlation to these lower prices to what I think people generally understand are the higher quality institutions. And if you think about it, it just makes sense. If you're good at what you do, if you're administratively efficient, that contributes to your ability to treat people well. You know, an administratively efficient organization where that crosses over into the clinical care too, if you're good at what you do, you're probably good at everything you do. So I actually think there's a pretty clear correlation to these lower costs and higher quality. I know that sounds counterintuitive, but think of it in the reverse. If your institution is just a mess, just a total mess, you're probably going to be a high-cost institution. So, you know, I am not willing to kind of accept that this range in here is somehow sacrificing quality. It's existing currently and often coincides with better quality. And in that case, you particularly want to financially reward something. So, but this is the kind of conversation that, you know, before we say, okay, now we're just going to pay this way, this is exactly the conversation that we need to have over this next year, particularly as individual principal accountable providers see their own information. And we are not defensive about the model at all. What we want to hear is why it doesn't work. You know, we want folks to come back at us to say, here's the problem, because I think it gives us a chance to really get it right.
With regards to that line, that threshold, are there safeguards in place to make sure that insurance companies don't arbitrarily lower it because they have a past few years and they want to push more people at the left side of the curve, less people on the right side?
They can do that today already, right? Because when they're negotiating their network, they essentially have this information already. So they already know who's in the red. It's just that you don't. And they know who to go after to cut loose from their network. Now, they also know who's over here, and they really do not want you to see this. Because if you had this, you would be able to maybe hold out on your contract and say, you know, I know I'm saving you money. So let's talk about this a little more before we sign. So it's more this idea of they already see this value. So why shouldn't you have it also?
I need to be respectful of Greg Moody's time, and if there's people who want to catch up on that.
I would take one more.
One more?
I love this. I know I'm keeping you all from home too, so just stop here in a second.
Here's an incredibly obvious question, but is everyone automatically enrolled? If you do joint replacement, are you going to get this information?
Or is it only for units for Medicare?
Nope, everybody. So now there are a couple reasons why you might not. So once we go through the process of exclusions, this doesn't work because remember, this is the average cost of care for a bundle for a principal accountable provider. If you get down to a very few number of cases and you have one kind of outlier, it can really throw this off. So statistically, you have to have a certain minimum number of cases for this to really work. So you could be, for example, a joint surgeon who did 2 joint replacements last year. You're not going to get a report because your N is just too small. So there are several reasons why certain folks might fall out of this. But anybody who build any of those plans that were up there will likely get a report. Now, the other thing that's confusing, because we did this the other day with some of the other associations, so the anesthesiologists really want to see their report. And we have to say, well, you're going to have to get that from the principal accountable provider. So, you know, it does create this, it's not a report that goes to every single member of the team that contributed to the bundle. As a practical matter, for a starting point, it goes to the principal accountable provider, but then those anesthesiology claims are listed there, along with the hospital and the pharmacy and everything that was billed. So the aggregate information at the plan level, if it's a Medicaid managed care plan, is public. But everything else we have carefully designed to include personal health information, which is all protected from public view. So the only thing that becomes public is that basically front page that rolls up. It's the summary information. But the information exists. The joint surgeon, if you bill Anthem, Aetna, United, and CareSource, you'll get this report for each of those payers.
When you showed that graph of where Ohio was 37, a lot of the states on the right are very high levels of obesity, smoking, poor access. Is that part of this plan as well to improve some of those public health modalities as opposed to just, because it obviously, if you have a healthy population, it's easier to keep it healthy.
Yeah, and clearly the answer to all of this is if we were just healthier, a lot of this goes away. So in this presentation, tonight, we really zeroed in on the idea of where we pay. Can we change how we pay to reward value? And it's very narrowly conceived. The real opportunities to change health are, for example, patient compliance. Making good decisions about how we live. Clearly that's the way to get at this. And we have other initiatives underway that try to contribute to that. But I gotta say, the governor is very, very practical. And when we came in, the view was essentially something like this. In 4 years, can we use government to change how individuals behave? Or do we have direct control over the money we spend to be able to change how the system functions? So hopefully over time there can be greater sensitivity to changing how people behave. And we had, it was actually, I'm a philosophy major, so we actually had a very philosophical conversation about the role of government in changing individuals' behavior. And we decided we had more control over what we spend than in changing individuals' behavior. Even though I know at the end of the day, changing behavior is the key. That's why patient-centered medical home makes a lot of sense. Patient-centered medical homes have a capacity to be more engaged with individuals, to actually maybe do a better job at finding those things that can start to change things. The other thing I'll say is in this next budget, we're doing a lot to organize how we do our population health planning. Ohio, for all its benefits of local government, there are some things that just kind of create bad results. We have 124 public health districts in Ohio. So for a patient-centered medical home in a region to want to contribute to improving population health outcomes, who are you talking to? Are you talking to the city or the county or the village or the... So we're going to encourage public health to plan regionally and to tie that regional planning to hospital community benefit. If a hospital has a responsibility to provide community benefit as a condition of its favorable tax treatment, why not expect that community benefit to be tied to improving regional population health outcomes? That's a really powerful idea. Now the problem is today, there's no regional population health plan. There are 124 public health district plans. So you have to plan up and then connect the resources. So you got a little preview of the budget there. I'm not allowed to talk about that. So, but we're going to be talking about that a lot over the next couple of months.
Thank you all. Thank you, Dr. Alfonso, Dr. Wolf, Dr. Applegate. And before you go, I just want to make sure to Greg, I have sent 2 emails to him in the last 4 years, asking him to come, and within a day he said yes. That's extraordinary for a person in his position to respond to us that way, and we're grateful. Those are the CMA members. There's now an app. You go to your app store, you can get a CMA Move app on your phone, and all the kinds of conversations that come out of nights like this and so on there. All right, thank you. Thank you all. Stay warm.